All right, we're back for platelets. So platelets, blood clotting, and blood typing is our second half of our blood chapter. So let's get into it. All right, so first, what is a platelet? Platelet is also called a thrombocyte, okay? And it's not a full cell. It's actually just a piece of a cell, a little fragment of a cell. So it's plasma membrane, has a few different types of enzymes in it and things, and it's involved in hemostasis, okay? So stasis means to pause or to stop, and hemo is blood, so to stop blood loss from an injury, usually to a blood vessel, all right? So one thing to know about platelets, because it's just a fragment of a cell, it's not going to have a nucleus and it's not going to have most of the membrane bound organelles that we see in a whole cell, like a white blood cell. Okay. Now, in platelets, you're going to see granules. Okay, granules. Now that's similar to what we saw in a leukocyte in a white blood cell, right? Okay, but a difference is going to be those white blood cell granules tended to have inflammatory mediators and lysosomal enzymes that would break down or kill pathogens. We're not going to see that in the platelet. In the platelet, these granules will have clotting factors, right? Enzymes, but not the same type of enzymes that we see in the leukocytes, some mitochondria, okay, just to give them energy, and little deposits of glycogen, which is fuel for those mitochondria. So even though it doesn't have all the other membrane bound organelles like the nucleus and the rough ER and smooth ER and all that, because they have mitochondria, they will be able to make energy. So they can do oxidative catabolism within their cells, their cell pieces, I should say. Okay. They also have parts of cytoskeleton. And the reason why they have cytoskeleton is to help them form clots, which we'll talk about in a minute. Okay, so they'll have microtubules, actin, myosin, in order to help them create these blood clots. All right, now here's just a picture of our platelet. Sorry, getting too close here with the camera. Okay, so our platelet here. So notice that again, not a full cell, it's a piece of a cell. There's no nucleus, all right? But we do see microtubules, we do see mitochondria, and we do see granules within these platelets, okay? So how do we form platelets? Because we were already talking about erythropoiesis and leukopoiesis, so making of the red and white blood cells. So how do platelets form? Well, the process is called thrombopoiesis. And these start as HSCs, right? And they're going to differentiate into something called a megakaryoblast, okay, megakaryoblast. And then these megakaryoblast will differentiate into what we call a megakaryocyte. This is where it gets weird, okay? These megakaryocytes, wait, sorry, did something weird here. Pausing for a second. Okay, sorry, it keeps looking like it's kicking me out of the PowerPoint, but I don't know. It probably doesn't look the same on the recording as it looks to me on my screen. So we'll just keep going. Okay, so the megakaryocytes, this is the weird thing that happens. They continually divide, so they undergo mitosis all the way up until the end, but don't undergo cytokinesis. Okay, so they do prophase, metaphase, anaphase, telophase, but they don't actually split. So what happens is you just get a big, huge cell with lots and lots of copies of DNA, lots and lots of organelles, huge in size. But since it never undergoes cytokinesis, it's just one big blob of cell rather than many, many new daughter cells. Okay. So big nucleus, big, huge cell, multiple copies of DNA. So what happens after this? Well, there is a hormone called thrombopoietin, right? And when that is going to be released, these megakaryocytes then make these little feet, all right, these little extensions, and stick those out of the sinusoids of the red bone marrow out into the bloodstream. Sorry, my face is so itchy. And then as those little extensions come out of those sinusoids, they break off and flow out into the bloodstream. Okay, so those are your platelets, just little pieces that are broken off from these big megakaryocytes. All right, now platelets poor platelets, have such a short lifespan. I mean, white blood cells do too, but we didn't talk about that today. We'll talk about that next week. But, you know, our red blood cells, we thought they were bad by having a lifespan of 100 to 120 days. Platelets live a week, 1 week. That's it. Okay. So you're constantly making new platelets, of course. So after a week to 10 days, platelets are going to be removed from the bloodstream by the spleen, and they can also be removed by the liver. So here's what that looks like. So we know HSCs, and we know that those are myeloid because all of our formed elements except for our B and T cells are myeloid. We get that megakaryoblast, and then those stick out, those little cytoplasmic arms, and break off into the bloodstream and become our platelets. Okay. So this is just showing all of those different cell lines, right, of our formed elements. Again, no memorizing of the whole developmental pathway. Just remember, we always start with their HSCs. You can be either myeloid or lymphoid, right? You go through all of these steps, at which time you are committed to becoming that one type of cell. But one thing that this figure is helpful with is helps you look at the different structural features of each of the cells, the functions of each of the cells, how prevalent they are, and their relative size compared to each other. Okay, so here we see our erythrocytes, our platelets, and our neutrophils and eosinophils. Here's our basophil, here our monocytes, and our B and T lymphocytes. So this is a good, nice figure that shows us all of our formed elements and all of the different properties of each one. Okay. All right. So that was short. Not much to say about platelets, right? But a lot to say about the process that platelets undergo to help the blood clot. That is hemostasis. Okay. I know I sound excited about this, but the only reason I'm excited about this is because I've taught this class out of a few different textbooks, and I find that this book is so good at really breaking down hemostasis and making it not as confusing. Like, I've taught hemostasis from some of these other books, and at the end of explaining it, I'm like, I don't even know what's going on, right? Okay, so this book is better. Now, I will admit, it is a little bit simplified. We could teach this in a way that goes so much more into detail. But I feel like I want you to understand the core of this, like the backbone of it. And then once you've done that, of course, as you go into subsequent classes, you can learn more detail about it. But the way that they break this down is it's very, very good and very clear. All right, so let's get started. Hemostasis is going to have 5 events, okay? 5 events. At the end of these 5 events, what you're going to have is a kind of jelly-like, so gelatinous blood clot. That blood clot will plug up and seal over the broken vessel to stop blood loss. Okay, so here are our 5 parts to this. Okay, so part 1 is a vascular spasm, which is what it sounds like. Vascular spasm, spasm of the blood vessel. Part 2, formation of a platelet plug. Part 3, coagulation. So if you've heard that term before, coagulation, so like thickening, okay? And there are 2 pathways for that, and we'll briefly talk about each of those. Clot retraction, so squeezing the clot down. And then thrombolysis, so breaking up the clot. That is a part of the process of blood clotting, okay? There we go. Okay, so part 1, our vascular spasm. So this is going to start at the immediate point of injury of your blood vessel. Okay, so think about it as you cut yourself, right? Imagine you get a paper cut, and immediately, as soon as you feel that paper cut, you kind of pull back. All right, imagine that happening, but in your blood vessel. Okay, so you get the paper cut and you feel that pain, right? You hold back and you close it. Okay, that's just the same kind of thing, except it's your blood vessel. The blood vessel gets cut and it kind of starts to go in reaction to the injury. Okay, so you get vasoconstriction, right? So the blood vessel itself tightens up, and then as some of the blood has escaped, you get increased tissue pressure around the outside of the vessel, and that kind of helps close it down around the outside. So the blood vessel will actually shrink from the outside and shrink from the inside. So as that happens, you're going to have increased blood pressure and then reduced blood flow. So minimal blood loss once you have that vascular spasm. All right. So here's what that looks like. So you injure the vessel, so it gets cut. Some blood leaks out into the extracellular fluid, applying pressure on the outside of it, right? So closing down the vessel from the outside. And then your vessel is actually going to spasm itself, helping to close off and not allow too much blood to flow out. These two processes together will decrease your blood flow and your blood loss. Okay, so part 2, we're going to make a platelet plug. All right. So a platelet plug isn't actually a blood clot. Okay. It's a little temporary patch. This is made mostly of platelets, and the platelets get sticky and they're going to stick to the area of the injury. And this is just going to enhance what we've already seen with the vascular spasm at reducing the blood loss. Because remember, the cut in the vessel is still there. And even though we've spasmed the vessel down and applied pressure to the outside, we could still leak some blood. So the platelets are going to seal off where we had the cut in your vessel. All right. So there's a few things that happen to help us form this platelet plug. First thing, our collagen fibers are going to be exposed. Remember, our blood is only supposed to be exposed to the endothelium, right? The endothelium is there, it protects us, it allows a smooth surface for the blood to glide across. When we break that, the collagen fiber, the connective tissue underneath, is exposed and it releases chemicals, all right? Now, those chemicals are going to include a few different things, but first one is von Willebrand factor. Okay, it's a glycoprotein, and it actually goes to the platelets and binds to they have receptors for von Willebrand factor right on their surface. This is going to activate them. Okay, so the platelets see the exposed collagen, they get activated by the von Willebrand factor, and they get sticky. So all the platelets that are in the area start grabbing and sticking to each other, and they stick onto the walls of the broken blood vessel. All right, now that happening is going to set off another trigger, all right, to activate all the platelets. It's called platelet activation. Yes, they made it easy for a change, all right? So those activated platelets are going to release their granules. Remember, we said that platelets have granules, right? Their granules have ATP, ADP, and some things that we might see it's part of other white blood cells like serotonin, and then things that aren't involved in the granules in white blood cells like calcium and particular clotting factors. Okay, now what happens when these granules are released? So when we degranulate, they're going to further trigger platelet activation. So they're going to make more platelets want to come over to the area, more platelets get activated, and then there's more and more of this stickiness clumping together we call aggregation of platelets. All right. So platelet aggregation is what's going to cause all the platelets to pile up onto each other, stick together, and temporarily seal the injured vessel. So why is this temporarily? Well, the platelets aren't really strong enough on their own to make a solid enough clot to stay there and completely, stop all of the blood loss. So then we're going to do our next step. Well, let's look at this step first a little bit. Okay. So we have our platelets there. You can see that the endothelium is broken. The collagen fibers underneath are now exposed. We're going to release von Willebrand factor from the damaged cells. So the endothelial cells are the ones releasing the von Willebrand factor. That's something important to point out because sometimes it gets confusing. It's like, is the collagen releasing the von Willebrand or is it the endothelium? It's the damaged endothelial cells releasing the von Willebrand. And the collagen fibers, just the fact that they're exposed, attracts the platelets because that's not how it's supposed to be. Only the endothelium is supposed to be seen by the platelets, but because the collagen is there, the platelets know something is wrong. Okay. So the platelets get excited, they get activated, and they go fill in that hole where the collagen is exposed. All right. Now, those activated platelets are going to send out more signals to bring in more platelets. Those platelets get activated, they get sticky, they come on, and they just build this whole platelet plug. All right. So next, how do we make that platelet plug a little bit more sturdy, more stable to help us seal it off and complete healing? All right. That's coagulation. All right. So this is going to be forming a glue that is going to infiltrate in that platelet plug and make it more solid. Okay. Now, here's where it can get complicated. There are two pathways, and this is going to really depend on where the injury started. Okay. Whether it'll go through the intrinsic pathway, which we can call contact activation pathway, or the extrinsic pathway, which is the tissue factor pathway. Okay. So in the end, they both end up the same, which is in the common pathway. And the common pathway just leads us to activate fibrin. Okay, so fibrinogen comes out of solution in the blood, turns into fibrin, helps us form the clot. Okay, so fibrin, as we said, is one of those proteins, right, that is part of the colloid in the plasma, right, made by the liver. And while it's floating around in the blood, it's in solution, all right? It's inactive and it's called fibrinogen. Okay. When it gets converted into fibrin by this coagulation cascade, which we'll talk about in a second, it's going to turn into a thread-like protein, okay? And it'll infiltrate its way into the platelet plug and make the platelet plug more solid. Now, how do we convert the fibrinogen into fibrin? It's going to be from the chemicals coming out of the surface of the platelets and the chemicals released by those damaged endothelial cells. All right. So this cascade has a lot to it. That's why I said this can be so complicated. You have a bunch of clotting factors also made in the liver, okay? And these are always circulating, but inactively, okay? So this is why you're not going to be throwing off a lot of inappropriate clots, because these guys are there in the bloodstream, but they are inactive, okay? Now, to make it just even more complicated, the clotting factors are named by just a Roman numeral. So it's clotting factor 1, clotting factor 2, clotting factor 3. They are not named in the order in which they appear in the clotting cascade. So it's not like, okay, we activate our platelets. Okay, here comes clotting factor 1. Oh, and there comes clotting factor 2. No, they are named in the order in which they were discovered. So you'll see clotting factor 5 before clotting factor 2. I'm just giving an example. We're not going to go that deep into when each one comes in, but they will be out of order because we didn't name them for when they appear in the cascade. We just named them by when we figured out what they were. I don't know why they didn't go back and change it. They did. Okay. So there are a few that specifically are going to depend on vitamin K for their synthesis. Now, we haven't talked a lot about vitamin K. We will talk more about vitamin K when we get to the digestive system and talking about nutrition and metabolism. But vitamin K, the large intestine plays a big role in us being able to absorb and use vitamin K. And clotting factor 1, clotting factor 7, clotting factor 9, and clotting factor 10 all depend on vitamin K for their synthesis. Okay. Now, first let's look at the intrinsic pathway. All right. So this is called also contact activation pathway. The reason why it's called this is because everything that you need for this pathway is in the blood. Okay, it's in the blood. So it's intrinsic, inside the blood. All right. So you have this whole pathway, right, that goes once you have factor, this is one clotting factor, 12, come in contact with exposed collagen fibers. So you already see 12 is the first one that we see. It's not 1, it's 12. Okay, so clotting factor 12 comes in contact with that exposed collagen and it activates, okay, into 12A. Now it becomes 12A. 12A now goes and finds clotting factor 11, clotting factor 11, in the blood, okay? It also finds clotting factor 9 in the blood. Those two are going to activate into 12A. Oh, sorry, 12A is going to activate 9 into 9A and 11 into 11A, okay? Then we have, I feel so bad because you guys are probably going to be trying to memorize all these. Do not, okay? Then we have 9A and 8A. I know, where'd 8A come from? Okay, 8A is there. 8A come together and they form like Voltron. I don't know if you remember Voltron. You guys probably don't remember Voltron. They come together like Voltron and make one big enzyme complex with calcium ions, okay? Now, then that enzyme complex is going to take factor 10 and activate that into factor 10A, right? Once you get to factor 10A, then you get to the common pathway, which we'll come back to and talk about. Right? But here's what that looks like. Okay. And you see in the figure, it's totally overly simplified. This is the level that I want you to know. Okay. This level. You have factor 12. Factor 12 gets activated by the collagen fibers. Now it's 12A. Just think 12A. A means active. Okay. 12A active. Then you're going to activate down here. We see 11. We see 9. Those two come together. And then, right, they're going to form this complex with calcium, which you can see in the bottom part, right? So you see 9A, calcium, 8A, right? Those make a complex. And then that complex activates factor 10 into factor 10A. All right, now let's look at the extrinsic pathway. So the extrinsic pathway is also called the tissue factor pathway. The reason why it's called that is because tissue factor is released, and that's the protein that's going to activate everything, okay? So extrinsic occurs outside of the blood, but it's usually going to occur at the same time as the intrinsic pathway, okay? So here you're going to have the subendothelial cells that have been damaged, okay? And they're exposed, and they're going to release tissue factor. Now here, instead of starting at 12, we start at 7, okay? So factor 7 is going to be activated into 7A, and then 7A plus tissue factor plus the calcium ions, again, come together and form the enzyme complex. And then those go on to just activate factor 10 to factor 10A. Here's what that looks like. All right, so we see that the subendothelial cells are releasing the tissue factor. That tissue factor is going to activate 7 into 7A. 7A, our calcium, our tissue factor is going to make a complex and convert 10 to 10A. So now we know in both the extrinsic and the intrinsic pathway, we're at the same stage. We have both just activated factor 10A. All right, both have activated factor 10A. So now what happens? Okay, so now is where we get into all of those proteins dissolved in the blood from the liver, all right? And those are going to come into play, come out of solution and help us strengthen our clot, all right? So here we go, 10A, and now it's going to combine with 5A, all right? Make a complex with calcium, go into the blood. In the plasma, there is prothrombin, okay? Prothrombin is inactive, okay? That complex, now called prothrombin activator, goes and activates prothrombin into thrombin, okay? So it just kind of changes it, makes it active, becomes thrombin. Thrombin now is going to find the circulating fibrinogen and then convert that into fibrin, okay, those fibrin threads. Those fibrin threads are going to go infiltrate inside that platelet plug and make it more of a solid clot, okay? It's going to hold that platelet plug together, all right? So just kind of take a quick second and look at the difference between if you had just a regular platelet plug right? Just associated platelets. And what the actual clot looks like now with our erythrocytes, our platelets, our fibrin threads, our leukocytes. So it catches anything that's out there and available and uses it to reinforce this clot. Okay, and you can see the fibrin threads there. There we go. Okay. So we do have a little concept boost, and it talks a little bit more about how we can make sense of the coagulation cascade. At the end of the day, this is what I want you to remember. Okay. There are three simple goals. First goal, get to 10A. Okay. Because both the intrinsic and extrinsic pathways end at 10A. Once you get to 10A, 10A is going to be able to turn prothrombin with the rest of the parts of the complex into thrombin. All right. Then thrombin is going to take fibrinogen and turn it into fibrin. Fibrin goes into that platelet plug and makes it a clot, seals it up. Okay. So just remember those three main goals and you'll have nothing to worry about, because I promise you, I'm not going to ask you to tell me in order where each of those clotting factors appear in each cascade. Okay, just remember your three goals and your 5 parts, of course. Okay, so next step, clot retraction. So we're almost done. We're at part 4. There's only 5 parts, right? Okay, so clot retraction, this is going to be as we're almost done making this clot. So remember, we've had the platelet plug, the platelets all get sticky, aggregate together. We've had the fibrin come in and weave, right, through the platelet plug, solidify it, caught other formed elements within the clot, right? So now your actin and myosin fibers, remember we have those pieces of cytoskeleton within our platelets, these are going to contract. And when they contract, they're going to bring the edges of the wound together. So meaning here's our broken vessel. As the platelets are over the top of it and they contract together, the edges of the wound are going to stick together. All right. And now they'll have a chance to heal, knit themselves back. Serum, which is just plasma without the clotting proteins in it, because we've taken the clotting proteins out of solution and put them in the clot, is going to be forced out of the clot. So a little bit of that fluid will come out and make the clot just a little bit more solid. Here's what that looks like. So there's the coagulated clot. You can see the fibrin and right everything else in there, our platelets. And then at the bottom, we're going to bring the edges of the wound together, right, by contracting those those microtubules, those actin myosin inside of our platelets, right? The edges of the wound are now close together so they can knit back together, and the excess serum is squeezed out of the clot. All right. And then last but not least, after our cell have knit back together, right? Our tissue is knit back together and our blood vessel is back in its normal non-damaged state, right? Bleeding's done. Blood vessel is now back intact. We have no use for our clot anymore, right? Okay. We have to break it down now. All right. That is thrombolysis. So we're going to break down first our glue. So we'll break down our fibrin. Okay. So what's going to happen is the healed endothelial cells underneath are going to release something called TPA. Okay. That's tissue plasminogen activator. All right. So this initiates the process of thrombolysis. So thrombo, remember, is clot. Lysis is to lyse, to break apart. Okay. There's another similar compound called urokinase that's made by the kidneys that can also initiate thrombolysis. And if TPA sounds familiar to you, we can synthesize TPA and give it to you to break apart clots when you have something like a stroke or a heart attack. Okay, so if you're thinking TPA, I've heard of that before, yes, you have. We make it in our body, and then we also can administer it to you as a clot buster. Okay, so TPA activates yet another protein that is floating around inactive in solution in your plasma called plasminogen. Okay, plasminogen is going to activate into plasmin. All right, and plasmin goes in and breaks fibrin apart. As fibrin breaks apart, all the extra parts of the clot that are still there, all the platelets, all of the other blood cells and debris and whatever, breaks apart, lets go of the endothelium, and the process is done. That is blood clotting. That's it. Okay. So we have, of course, our figure 19.6, which puts it all together. We can see those last couple of steps. Our TPA is released from the healed endothelium. TPA is going to turn plasminogen, an inactive state, to plasmin, the active state. Plasmin goes into the clot, breaks apart the fibrin, and all the different parts of the clot dissociate from each other. Clot dissolves, and now we have our perfectly healed endothelium of our blood vessel. Okay. So this 19.17 shows you every single step. So all 5 of our steps, and of course the simplified cascade here. So the extrinsic and the intrinsic, which again, you want to know those 3 goals, right? You can see that there. And then as we coagulate and as we retract, and then thrombolysis. Okay. So if you're looking for an easy way to just visually understand blood clotting and get it all in one place, this figure 19.7 is a very good place to start. Okay. So this is one table that I'm going to tell you. Don't memorize. Do not memorize this for our test. I am not going to ask you about this, okay? But it's a good tool to kind of have at your disposal for later on if you ever want to refer back and say, oh gosh, I really want to remember all these clotting factors. I wish it was explained to me in a simple way. Refer back to this in this particular book, because it shows you all the clotting factors, describes them briefly, and tells you their function. So especially the ones that are dependent on vitamin K, and they all have, you know, proper names in addition to their Roman numerals. So you see that there's label factor, stable factor, anti-hemophilic factor, A, Christmas factor, Stewart factor. I mean, there's so many. Again, I don't want you memorizing these. And notice that some of the ones that we refer to by proper names actually have a Roman numeral for their clotting factor. So fibrinogen is clotting factor 1. Prothrombin is clotting factor 2. Just make it more and more confusing, right? Okay, this is why I don't want you to memorize these. And okay, just what we've done so far and what I've asked you to focus on should be your focus for this part of the exam. Okay. Now, how do we regulate clotting besides just being able to dissolve the clot in the end? Okay, well, blood clotting is an interesting one because this is an example of a positive feedback mechanism. And we know that we don't have a lot of those positive feedback mechanisms. It's like childbirth and blood clotting, okay? So this has to be very tightly regulated so that we don't end up having a catastrophe where blood clotting starts and it's not able to stop, okay? So we do have some stopgaps. And these are chemicals that are released by the endothelium that will help to regulate the first stage of clot formation and the second stage of clot formation. So first, prostacyclin. Okay, this is a type of prostaglandin, and usually when we think of prostaglandins, we think of mediation of pain, but in this case, prostacyclin is inhibiting the aggregation of the platelets. So it keeps the platelets from getting all sticky and forming these platelet plugs. And then there's nitric oxide, which instead of allowing vascular spasm to occur, it's going to cause vasodilation. Okay. And our endothelial cells and our liver cells, our hepatocytes, can also make anticoagulants. So this is funny, right? Our endothelial cells, which can trigger platelet aggregation, and our hepatocytes, which make the actual proteins that make clots, also produce substances that inhibit clots. I know, right? Okay, so first one, antithrombin 3. So this is going to bind factor 10A and thrombin and inhibit their activity. Okay, so by binding 10A and binding thrombin, you cannot make new thrombin. All right, can't make new thrombin. Then there's heparin sulfate. Yes, you know this because we administer heparin in the hospital in order to prevent blood clotting. Well, guess where we got that idea from? Your own body. Okay, our own body makes heparin. And heparin is just a polysaccharide, so it's a big starch. and it enhances antithrombin activity. So enhances that antithrombin 3, okay? Then we have protein C. When protein C is present and it's activated by a secondary protein, protein S, it's going to degrade clotting factor 5A and clotting factor 8A. All right. Okay. So here's just a table of those clot regulators. Okay, TPA, urokinase, plasmin, and then prostacyclin, your antithrombin 3, your heparin, and your protein C. All right. So just have an idea of those and what they do. Okay. So you can have disorders of clotting. So your clotting disorder means that for some reason, and there are several different reasons, your clotting is not regulated properly. Now there's two main types. Either you have a bleeding disorder or you have a hypercoagulable disorder. Okay. So losing too much blood or clotting too much. So first, bleeding disorders, and you might have heard of these. This is going to increase blood loss, and this is even from a minor injury. So from something like a paper cut or a, stubbing your leg and getting a bruise. You have some kind of clotting protein deficiency, so you're not able to clot your blood. So hemophilia is the one that we think about the most when we hear about a bleeding disorder. So hemophilia A is caused specifically by having not enough factor 8. And hemophilia B is caused specifically by not having enough of factor 9. Okay. Now, these are going to be disorders that are actually sex linked and inherited. So we tend to see hemophilia, both A and B, more in males. Okay. Then we have the other side, hypercoagulable disorders. Here you make too many clots. So you make inappropriate clots or thromboses, okay? So the reason why this is bad is that if a clot obstructs blood flow through a vessel or it breaks off and moves to another area where it can occlude a smaller vessel, that's called a thromboembolism. These can cause tissue damage or death, all right? So we do not want this happening. So sometimes you can get thrombi that just occur in the deep veins of your legs. Okay, that is called deep vein thrombosis. So this can happen for a lot of different reasons. One time when we see this a lot is when people are not moving much. So let's say you have a long haul flight and the blood is pooling in your legs, you could form a little clot. And then once you start moving again, that little clot can move away, get into the lungs, which is our next thing here, pulmonary embolism. It can go into the brain and cause a stroke, go into the heart and cause an MI. All right. So these are all very, very dangerous conditions. Of course, we know it's not always necessarily fatal. One example of pulmonary embolism is Serena Williams actually has had this happen to her more than once. She injured her foot and then she took a flight and the clot that was in her leg went up into her lungs and she had a pulmonary embolism. They treated her with blood thinners and she was fine. But again, when she gave birth to her daughter, she was having a shortness of breath feeling and begged for them to give her a chest CT because they didn't want to at first. Begged for them to give her one. And she did have several clots again within her lungs. Okay, so this can happen. It can be fatal, but it can also be caught and treated. Okay, so speaking of catching these and treating these, anti-clot medication. Okay, so if a patient comes in and presents with a thrombus or an embolus, we treat them with drugs that slow down or stop the clotting process. So first, of course, anticoagulants. Okay, so we know heparin and those, related to heparin. We can only use these in hospitals. This has to be injected. Okay, it's nearly immediate in action. But again, you have to give it as an injection, okay? Now, we can also manage blood clots in an outpatient setting with drugs like warfarin. Warfarin's been around for a long time. You may know it by its proper name, Coumadin, right? Okay, so you can give this by mouth, by pill. And what Coumadin does is it inhibits the production of vitamin K dependent clotting factors in the liver. Okay, so those factors, don't memorize this, are 2, 7, 9, and 12. Okay, it won't affect the clotting factors that are already in your plasma. So once you start taking Coumadin, it takes a few days for a noticeable effect. One of the downfalls of Coumadin, though, is that you have to monitor your diet. So if you eat a lot of food that is vitamin K rich, so a lot of green leafy vegetables, you're going to have to modify that. Okay, so you got to give up the kale and all of that once you take the Coumadin. We also have aspirin. Okay, aspirin is a pretty easy way to get there because aspirin is a prostaglandin inhibitor. So it inhibits the enzymes that contribute to the aggregation of your platelets. Then we have things like clopidogrel and these other newer anticoagulation medications, right? These are different in that they block the platelet receptors and they inhibit platelet activation. There's a glycoprotein 2B and 3A inhibitor that we can use for heart attack patients. It works the similar kind of way. The things that are better about these is that these don't require any dietary restrictions, and they're also not, you don't have to constantly monitor. So one thing that happens with Coumadin patients, you have to constantly take their PT and their PTT, which is prothrombin time, to make sure that the levels are not too high and that they are going to be at danger of internal bleeding. With these newer types, the Xarelto and those other ones, you don't have to do as constant blood monitoring, and they can eat all the kale salads that they want. Okay. Now we have also thrombolytic agents. Now these aren't treatments that you take at home. Okay. Or that, this is for you have the clot there. Clot's there and it's messing with your functioning. Okay. TPA or urokinase are going to be administered to you to help restore blood flow. All right. So after a stroke or a heart attack, give you the TPA or the urokinase, and this will help break the clot up and help prevent damage to the brain and the heart muscle. All right. So our last part of this lecture is our blood typing and matching. Now, I find this to be really kind of interesting because they didn't know all of this information at first when they first started to try to do blood transfusions. So it was very often a very catastrophic type of thing if you gave a blood transfusion. All right. So, what is a blood transfusion? I think you know the definition, but let's just state it. All right. Just to be clear, you have a donor, they give the blood, and the person who receives the blood is called the recipient. Okay. It's used a lot nowadays. It's pretty mainstream. Get a blood transfusion. It's not even something that's thought of. Okay. But back in the day, we thought blood was blood. Blood is blood. You give blood, take blood from one person, give it to another person. We didn't know about antigens. Okay. So antigens are the markers found on the outside of your cells. Erythrocytes have antigens. Antigens can be seen by another body as foreign if they don't match yours. Okay. So if you give blood with A antigen to someone who has an anti-A antibody, which we'll get more into later, that body will reject that blood because it's recognizing those antigens on that blood as foreign. Okay. Your body will try to remove those foreign antigens. So a lot of people died in early transfusions because the antigens were not matching up with the antigens in the body of the recipient. Okay. So now we know that the antigens on the erythrocyte give rise, so make us have these different blood groups. All right. We can identify those different blood groups very easily by testing the blood of the donor and the recipient and matching them up. Okay, so we figure out mainly for transfusion, as long as you're not someone who's sensitive to blood product, what your ABO blood group is and what your RH blood group is, and we can match the blood that we should give you. Okay, now that's not the complete picture. We're not going to go past it, but it's not the complete picture because there are actually 30 different antigens that can appear on your erythrocytes, and people who are sensitive to blood products may have to do a more extensive type of matching, looking at more than just those two types of antigens to receive blood products. But that's something for another day. All right. So here is what your blood can look like. Okay. the ABO groups first, okay? ABO group just has, unlike its name where you see A, B, and O, it just has two antigens, A antigen and B antigen, okay? Now, between the A and B antigen and combination of them, we can have four different blood types, all right? Now, if you're blood type A, your blood cells look like the ones on the left. You have A antigen on your erythrocytes. If you are blood type B, your blood looks like here on the right. You have just B antigen. If you are blood type AB, you have both A and B antigens on your erythrocytes. And if you are blood type O, just think of that as zero. You have zero antigens, okay? You do not have A, you do not have B, okay? You have no antigens. Now, there's a third antigen that we look at, RH, okay? So RH, it's called RH because it was discovered in rhesus monkeys. Sometimes when you're doing the blood typing kits, you'll see D instead, like it'll say anti-D. That's the same thing, okay? RH antigen is D antigen, just some places it's called D, some places it's called RH, okay? So we'll indicate if you do have the antigen that you are RH positive. If you do not have the antigen, we will say you are RH negative. So we put those two factors together, and then that's how we determine your blood type. So let's say you have A antigen and you have no RH factor, okay? Your blood type would be A negative, all right? The most common blood type in the United States is O positive. AB negative is the least common. So when we're blood typing, what we do is we use antibodies. So we actually have synthetic antibodies that will bind to the antigens on an erythrocyte. Okay, so we'll have some blood and we'll have an anti-A antibody, an anti-B antibody, an anti-RH antibody, and we will test it on the blood. Okay, so these antibodies, we call them agglutinins in this case when we're looking at doing the ABO-RH blood typing. They're going to bind to the antigens on the blood, okay, on the erythrocytes. When these antibodies bind onto the antigens, they cause the blood cells to clump together. That's called agglutination, okay? After agglutination, what's going to happen is it's going to form as like a beacon for white blood cells to come and destroy the erythrocytes, okay? So it actually, in the end, causes hemolysis. So here we see our erythrocytes with our A antigen. We have our anti-A antibody. They bind and group together, agglutinate all of these A-type erythrocytes, okay? And as they're gathered together, that's going to send a signal to the white blood cells. They'll come in and actually destroy our donated red blood cells, okay? So how do we do blood typing in our, how do we figure it out in our heads? Because we're not going to actually do it hands-on, but you will have some virtual activities that will simulate this. Well, what you would do if you were in the lab, you would treat each blood sample with all three antibodies, type A, type B, and RH. If you see agglutination, that means that particular antigen is on the erythrocyte. Okay. If you see no agglutination, that means that antigen is not there. Okay. So anti-A antibodies will signify, if you see agglutination, that there are A antigens. So if you have a sample of blood, you put anti-A on it and it clumps, that means that blood has A antigen. So it's type A blood. Okay. With B, if you have anti-B antibodies and you put it on a sample of blood and it agglutinates, that means that blood has B antigen. So it's type B. If you put anti-RH antibodies on that blood sample and it agglutinates, that means you have RH antibodies, okay? Now, if it does a combination of these, that means you have a combination of blood. So let's say you put anti-A, anti-B, and anti-D on a blood sample and all three agglutinated, that particular blood is AB positive, for example, okay? So here's just what that looks like. If we were doing it in the lab, all right, it would look like this. You would have samples that look like this. As you do it in virtual, you will get the same kind of results, all right? So here is one blood patient with blood type A. As you put the anti-A on it, right, it agglutinates. As you put the anti-B antibody on it, nothing happens. It doesn't agglutinate because it doesn't have B antigens. Yes, Madison, I know, right? Hold on, we're gonna pause. All right, so next line, okay, B. Notice that when we put the anti-A antigen on the type B blood, we see no change, but when we put the anti-B, we see the agglutination. And then for AB, anti-A and anti-B antibodies both showed agglutination, right? Showing the presence of both A antigen and B antigen on the surface of those erythrocytes. And then on O, remember, we don't have B or A antigen on type O blood. So both are unchanged, okay? All right. Now, when we're getting a blood transfusion, we know our immune system recognizes our own antigens that are on our red blood cells as self-antigen, right? So it doesn't produce antibodies to our self-antigen. Now, next week when we talk about immune system, we'll talk about where things can go wrong. But if it produced self-antigen, the antibodies would bind to its own antigen and we'd have hemolysis all over our body, right? But what our immune system does do is make antibodies to foreign antigens, okay? So antigens that are non-self. So if these antigens are somehow introduced into our body, the antibodies that we have will attack it, okay? All right, so one thing to remember, and this is kind of an odd fact, A and B antibodies, so anti-A and anti-B antibodies, are already in your plasma. Even if your blood has never seen, if your body has never seen type A blood, never seen type B blood, never seen those antigens, your body already knows them. You already have anti-A and anti-B floating around in your bloodstream, okay? If you're like, let's say type O, okay? If you're type B, you have anti-A floating around. If you're type A, you have anti-B floating around, okay? Now, Rh antibodies, you only get them if you've been exposed to blood that has Rh antigens. Now, specifically, if you are Rh negative, you do not have anti-Rh antibodies unless your body has been exposed to Rh, okay? So again, Rh negative, no anti-Rh antibodies unless you have been sensitized, so somehow exposed to Rh positive blood, all right? Now, we use these antigens and these antibodies to do blood matching, okay? We take blood from the donor, screen to see what type of blood it is before we give it to the recipient, okay? Now, why do we do this? Because the patient can't get blood that has antigens that your immune system would see as foreign, okay? So the match occurs, that's why they say type and cross. If you ever see when they talk about, giving blood, they say type and cross and make sure that blah, 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 or they just give you O negative, okay? So a match occurs if the donor type is compatible with the recipient's type, all right? If it's not, if there's a mistake, we don't type and cross properly, or we don't type and cross at all, we just say, oh, here's O negative, and we give it to them without typing and crossing first, you can have a transfusion reaction, which means that your antibodies, as the recipient of the blood, will bind to the antigens of the donor blood and cause massive agglutination, okay? So the donor erythrocytes will be destroyed. Your erythrocytes will be fine, but the donor erythrocytes that you needed to supplement the blood that you have in your body will be destroyed. And those agglutinated, right, complexes of the erythrocytes, the donor erythrocytes, can get into your vessels and actually lead to kidney failure or even death. So it's very important for us to be able to make sure we have typed and crossed properly so that we're not giving non-matching blood products to our patients, all right? So here's just some examples. Okay, so Sue is B negative, okay? So her immune system doesn't make anti-B antibodies because they would attack her own erythrocytes. But She does have anti-A antibodies, okay, because she doesn't have A antigen, and she has Rh antigens. She has anti-Rh antibodies, okay? For some reason, she's been exposed to Rh positive blood. So she has those anti-Rh already in her blood, okay? Now, she cannot receive blood with A antigen or Rh antigen. So that makes her not able to receive A positive, A negative, B positive, AB positive, AB negative, and O positive blood. The only blood she can receive safely is B negative and O negative. So why only B negative and O negative? Because B negative does not have A antigen and does not have Rh antigen. O negative does not have A antigen and does not have Rh antigen. So those are the only two blood types that are safe for her to get. Okay. Now, what if Sue wanted to give blood? Sue can give blood only to people who don't have anti-B antibodies. Okay. So the recipients for Sue's blood can be B positive, B negative, AB positive, and AB negative. Okay. All the other blood types will have anti-B antibodies, so they'll agglutinate her donated erythrocytes. So why don't we worry about Rh in this case? Because she is B negative. So she doesn't have any Rh antigens on her blood. Also, her antibodies that are in her blood don't matter when she's giving blood. Okay. So the number of her antibodies will be negligible when she's giving blood for a transfusion. Okay. The antibodies that you have in your blood only matter when you're the recipient. Okay. Your antibodies don't matter when you're the donor. You just have to worry about the antibodies in the donor and make sure your antigens that you're giving them are going to match up. Okay. So here's just what that looks like. Okay, your type O. Type O is the universal donor, okay? Because it has no A antigen, no B antigen, no Rh antigen. So they can give to anybody, okay? And there'll be no agglutination. So we see this type O negative giving to someone who's AB positive. They have all the antibodies. They have all the antigens. So they don't have any of the antibodies. All right, so there'll be no agglutination. Here's another example. So donor AB positive, they really can't give to anybody except people who are AB positive. Because if you see the recipient here would be type O negative, they have anti-A, anti-B, and anti-Rh antibodies. Immediately that blood would agglutinate. Okay. So AB positive actually is universal recipient because AB positive has no antigens. No antibodies. Why? Because they have all the antigen present on their cell surface. Okay. So O negative, universal donor. AB positive, universal recipient. Okay. So just as I mentioned, here's your blood type O negative. All right. No A antigen, no B antigen, no Rh antigen. You can give O negative to any other blood type in an emergency when blood matching is not an option. So that being said, we always want to type the blood and give them blood that is the same as their blood type. In a pinch, we can always give O negative, okay? But it's better to match by blood type. But this is why whenever there's a disaster, they're always looking for people to give type O negative blood because this is one that is a universal donor, okay? Now, universal recipient, as I mentioned, type AB positive, okay? They don't make any antibodies to A, B, or Rh because they have all the antigens. So you can't make antibody against something that you have an antigen for. So they can receive blood from any blood type. But again, matching is still the safest practice. Okay, so here's all the 8 major blood types. All right, so AB positive, AB negative, and going down the list. And it shows you how much of the population has each type. As we can see, by far, O positive is the most, and followed closely, kind of, by A positive. All right, and then what antigens are on its surface, what antibodies are in their plasma, who they can receive blood from, and who they can donate to. Now, you don't necessarily have to memorize this table. you can use reasoning to kind of try to figure out, okay, this person has B positive blood. What antigens are on their surface? The B antigen is on their surface, the RH antigen is on their surface. So I know that if they have B antigen and RH antigen, which antibodies can they have? They're going to have anti A antibodies. So I know that they won't be able to receive any blood that will have A antigens on it. Okay. And I know that they can donate blood to anyone who can accept a B antigen or an RH antigen, for example. So you don't have to necessarily memorize this table, you can work it out. And I'm going to assign a few extra, I did put some extra study information in the course information folder about blood typing. All right, so you can look at that and kind of practice some of those because you will have to do this both in the lecture exam and for lab. So it's good to get a little bit of practice. And I'm going to actually give you some dynamic study modules, not mandatory, not part of homework, just extra if you want to practice to, kind of get used to, um, doing some of these blood typing problems. Okay. All right. So concept boost. I already kind of told you this, so I spoiled it. What about the donor's antibodies? So, of course, the donor is going to have antibodies against different types of blood. So they can bind to the recipient's antigens. And unless the blood types are exact, you might destroy a few erythrocytes. But the issue is you're not going to be making more antibodies because the blood's already out of you. Okay. So only a few of the erythrocytes will be affected in the recipient's blood. Okay. You're not going to harm the recipient with your antibodies. Once you give the blood, there's a few of your antibodies in there, but it will be a very limited reaction. All right. So here's an example. Donated O negative. Okay. They gave to, the recipients, right? Tom, who got the blood from Ed, is AB positive. Let's say there were 100 antibodies that were anti-A, anti-B, and anti-RH in Ed's blood sample that he gave to Tom. Okay. You might destroy 100 of Tom's erythrocytes with those 100 antibodies. But Tom has received millions of erythrocytes from your sample. So he won't really miss the 100 erythrocytes that would have been killed by his antibodies that are in his blood sample. Okay. So we really don't have to worry about that when we give blood or receive blood. So another example, okay, Tom donated his AB positive from Tom. No erythrocyte antibodies from Tom, okay? Ed is O negative. We already know Ed can't get blood from anybody but O negative. So this is going to be a disaster getting AB positive blood from Tom, right? Okay. So there's thousands to millions of Ed's anti-A, anti-B, and anti-RH antibodies waiting in his bloodstream for this infusion of AB positive blood. Not good. Okay. So Ed's leukocytes come into contact with Tom's erythrocytes. Ed's immune system goes bonkers. All right. Makes millions more antibodies, anti A, anti B, anti RH, and give a huge transfusion reaction. And Ed's antibodies destroy every single donated erythrocyte from Tom. Okay. So, what is the take home at the end of this? Worry about the donor's antigens and the recipient's antibodies, not vice versa. Donor antigen, recipient's antibodies are the two main things to worry about. All right. So, one thing that I sometimes ask this on bonus, but I have asked this on the exam. So this is one of those A&P in the real world where I'm like, okay, this could appear on the exam. Hemolytic disease of the newborn. Okay, also known as erythroblastosis fetalis. What does that mean? It means that the mother's antibodies can destroy the erythrocytes of the fetus. Okay, so this occurs only in one case. Rh negative mother gives birth to an Rh positive fetus. First pregnancy is fine. Okay, first pregnancy is fine. What happens is during the birth, some fetal red blood cells can enter the mother's bloodstream. the mother's immune system now makes anti-Rh antibodies. Because remember, you can't make anti-Rh antibodies unless you were exposed to Rh antigen. Okay. So the first baby's been born, they're fine. All right. But if you get pregnant again as an Rh negative woman with another Rh positive fetus, the anti-Rh antibodies can cross the placenta and actually destroy the fetal red blood cells, okay, the Rh positive fetal red blood cells. So we can prevent this. We know how to prevent it. All we do is screen. If a woman is Rh negative, what she's going to be given is something called RhoGAM. Okay, what RhoGAM is a Rh immune globulin. So what it'll do is it has the anti-Rh antibodies that will bind up the fetal cells that escape into the maternal circulation. This is right when she gives birth for the first time with the Rh positive baby. All right. So this is going to prevent maternal production of the anti-Rh antibodies, so the subsequent pregnancies will be safe. All right. All right. So that is our chapter 19. Check back next week because we will do a review of what we did in our chapter 19 with a case study, as we do every week. All right. So again, if you have any questions, email me, come by office hours, or hit up the discussion board and keep a lookout for, well, the homework's already posted, but for those extra little study guides, right? They're already in the folder, and the dynamic study modules, which will be posted this week. Remember, they are not mandatory. They're not part of homework. It's just extra to help you out with some of these really tough things that we've gone through so far with the circulatory system. All right, thanks so much for listening, and I will see you next week. Have a good one.